Thank you for joining us for this clinical athlete webinar titled Tendinopathy Management, Science-Based Rehab for Athletes. Clinical Athlete is a network of healthcare providers who specialize in the management of athletes. If you are an athlete and/or an active individual in need of healthcare from a professional who understands your performance goals, find your nearest clinical athlete provider at clinicalathlete.com. If you are a healthcare professional who wishes to become a clinical athlete provider and be part of the forum community, or a student or coach wishing to be a part of the Clinical Athlete Forum community, where all past webinars can be found and where we share and discuss ideas and resources related to sports medicine, rehab, and performance. Applications for all of this can be found at clinicalathlete.com. Finally, all upcoming clinical athlete events and continuing education courses can be found at clinicalathlete.com. Enjoy the webinar. Jason Ure is going to learn us all about tendinopathy management, and he's going to give us a science-based approach. And Jason is a physical therapist in Fairfax, Virginia. He's got a bachelor's in human nutrition, foods, and exercise from Virginia Tech in 2011, where he was also working as a strength and conditioning coach at the University of Richmond. And so he's got that coaching background to supplement his DPT, his doctorate in physical therapy, that he earned in 2013 at the University of St. Augustine. So he's kind of, again, he's got this clinical knowledge and this knowledge of strength and conditioning. He's molding that into, helping the athletes that he's working with today.
All right. Well, thanks, Quinn. So I'm Jason, as Quinn said, and the talk I'm going to be giving today is on tendinopathy management. So I'm going to take all the relevant scientific data and compile it for practical use in athletes. So what I'm going to be going over today is going to be tendon anatomy and physiology, mechanisms of damage, pathology, rehab principles, and then return to sport. So I kind of want to hit this preemptively. A lot of the early material in this lecture isn't exactly specific to the clinical setting, but it doesn't mean that it doesn't heavily influence what we do or why we do it. So if you only have a superficial understanding of tendon characteristics and how these qualities influence muscle-tendon interactions, it leaves you vulnerable as a clinician or an athlete yourself. So with a solid foundation of knowledge, you're able to enhance the precision of your exercise prescription, and you're able to navigate difficult presentations because you understand the impact that manipulating those variables has on the pathology or the rehab. So I'll try to make this apparent throughout, because pretty much everything I introduce in these early sections, I'm going to refer back to later once I talk about exercise prescription. All right, so anatomy and physiology, nobody's favorite topic here, but I just want to hit on this really quick. So tendons are structured in a highly organized hierarchy. So you have collagen fibrils, which are aggregated to form collagen fibers, which again aggregate to form fascicles, and then bundles of those fascicles form the tendon. And then surrounding the collagen fibers, there are sheets of tenocytes or tendon cells, and they're responsible for maintaining the cellular and extracellular environment around that tissue. And then interspersed between each one of those levels is a matrix of proteins and proteoglycans, which have a lot of function when it comes to altering the stress on the tendon. All right, so if we talk about tendon function from a tissue level or a macro scale, there are a few main features. All tendons are responsible for transmitting force from muscle to bone. Everybody kind of knows that. But from here, it kind of depends on the tendon type we're talking about. So there are a few key differences in terms of the composition and structure of tendons, which give them unique properties. And this leads to two primary classifications. First, you have positional tendons, and this is like your supraspinatus, that are responsible for positioning limbs for optimal function. Second, you have energy storage tendons, and this is more of your Achilles tendon or your patellar tendon. And they're primarily useful for amplifying force and enhancing movement efficiency. Let's see, okay. So I had a couple of videos here that illustrate the concept of viscoelasticity. I'm going to go ahead and skip them because we had a couple issues when it came to the technology here. But what I want to talk about is that a major function of the tendon dynamics stem from this property. So when it comes to mechanisms of damage and then our exercise prescription, it plays a big role. So first, the collagen structures in the tendon act primarily elastically, as in they deform a standard amount per unit force. And that's regardless of the speed of application of the stress. And they'll return to baseline length pretty much immediately after the removal of the stress. Second, the matrix around the collagen is highly hydrated and acts more viscous. In other words, it's going to deform depending on the rate of stress application, and it doesn't immediately return to the same baseline length. And then the last kind of macro scale characteristic I want to talk about is how tendons act as a biological capacitor. When we perform a movement, the lengthening of the muscle and tendon are out of sync with each other. So the tendon stretches first, and what this does is it allows the muscle to remain in an optimal length tension relationship for a longer duration. So it's going to enhance its contractile capacity. And then when the lengthening does occur, when the tendon contracts and the muscle lengthens, importantly, this is going to occur at a slower rate. So what this does is it spares the muscle from the high strain rates and helps reduce injury. And then when we move to the micro scale or the nanoscale, and this is basically everything from the fascicle level and below, a few characteristics exist which have big implications for the way we're going to load it later on. And the most important one I want to talk about is crimp. This is the wave-like structure that tendons have when they're not under load. And this crimp pattern is what gives us this toe region here in the stress strain curve. This is where there's a non-linear deformity based on how much you're straining the tissue. And then the last key feature I want to talk about is interfascicular sliding. It's an interesting area of research that's going on currently, but like for today's talk, it's not entirely relevant. The main point is that there are mechanisms which connect adjacent collagen fibers, and that allows them to reduce stress experienced individually. And the main components that allow for this are the cross links between the structures, as well as the hydrated extracellular matrix, like the proteoglycans between it. So I want to take all of that information and kind of relate it to how damage accrues within a tendon. This is a direct quote from a paper that came out this year that strikingly little is known regarding the actual mechanisms behind originally healthy tendons accumulating damage. So this indicates that we still have a really long way to go in terms of our understanding of the condition generally. But I would say this is a little too dismissive because there's actually quite a bit of evidence into the mechanisms that we do know that I'm going to be going over here in a minute. But if we take a step back and look at this from like 10,000 feet above, what we can say is that generally tendons are damaged when the applied loads exceed our body's ability to adequately respond. So the two main theories you'll see floated out there in the literature are the ideas that tendons suffer from overuse or underuse. And I kind of want to dig into them a little bit. So right off the bat, I want to say I hate the term overuse. The word implies that there's an absolute threshold of stress that if you exceed it, you'll do harm. But in reality, that ceiling of stress tolerance is always fluctuating based on many factors. Instead, you want to view the problem as a ratio, and that the stress applied differs compared to the person's current capacity and their intrinsic adaptive capacity. So on the right here, this figure is based on Scott Dye's envelope of function model, where he discusses appropriate levels of stress to maintain homeostasis or induce some sort of change. And I'm going to be, you'll be seeing this a couple times here in the slideshow, but for our purposes here, when we're talking about too much load, we want to look at this top region here, the zone of structural failure. So does tendon damage occur due to a single traumatic incident? Everyone's probably treated a patient, or at least they know someone who's come in with a story of landing or cutting and their Achilles tendon pops, right? But this isn't really how the typical tendinopathy happens. Most often, there's no singular inciting incident. When we look at the data on tendon stress, what we see is there's this huge discrepancy between strain experienced on a daily activity scale, so like you'll see less than 4% strain, and then the strain required for failure, which is greater than 12% strain. So this indicates that most often, tendon pathology arises from the accumulation of micro injuries stemming from cyclical loading. And so what's going on behind the scenes? It has to do with kink band formation. So this slide's pretty busy. I just put this here for a reference. I wouldn't worry about actually reading through all of this. But so what's going on is that when a collagen fibril is loaded beyond its capacity, we see kink bands form in isolated little sections. And then if that continues, it's going to spread along the length of the fibril, and then eventually you're going to have a loss of structural integrity. And if we zoom in on that process, so this all goes back to that viscoelastic nature of the tendon. So if you look at stage 0 of this image, you'll see the characteristic crimp that's present when it's unloaded. And then when it's loaded in the second half of stage 0 here, and then it's subsequently unloaded, there's not an immediate resolution of that resting length. So over time, we see this length continue to creep to the point where you get a lateral bowing, like you can see down at the bottom of this image. And again, this is all due to that viscoelastic nature not allowing it to return to its normal length. And so if this bowing continues, eventually this is going to lead to kink formation within the fibrils. And if this process continues, like say you're cyclically loading the structure, you'll get a lateral progression of the kink banding. And eventually this is going to impart enough compressive stress on that fibril to the point where it's going to rupture on the micro scale. And just to give you a clear picture of what this looks like in an actual structure, this is just a blown up picture from a tendon where you see the kink banding in the picture on the right. All right, so that was the case for overstimulation. What about the opposite, the argument for understimulation? So interestingly, when you look at prevalence rates on tendon pathology, there's a disproportionate amount seen on the joint side of the tendon. And when you compare this to incidences when they map strain distribution on the tendon, this is actually the area that experiences the lowest levels of tensile load. So this has led to the proposal that tendons may actually undergo a degenerative process when they're stress shielded or they're not stimulated enough. So everyone always has this knee-jerk reaction to assume that catabolism or degradation is bad. But that's really not the case, because collagen degradation is an essential component for maintaining homeostasis. It's really important for remodeling of the tissue. And primarily, this process is going to fall in a group called matrix metalloproteinases. And because I don't want to say that, I'm just going to call them MMPs within the tendon. So what do the MMPs do? They're going to remove damaged or unwanted components of the matrix. And important for today, what we need to know is that their activity is modified by collagen strain. So tensile strain has been shown to reduce or even completely prevent proteolytic damage at normal levels associated with common daily occurrences. So this leads to the natural conclusion that if the tissues are chronically understimulated, this suppression won't happen, and there may be excessive degradation of the collagen matrix. So this chart here, you can see how the level of MMP activity is based on tissue level strain. And I just want to highlight a couple areas here. So when there's a moderate level of loading applied, there's virtually no activity of MMPs, meaning that the degradation is being suppressed. But if too little load is applied or too much load is applied, we see basically the same response where there's high MMP activity. So how does this occur even if you're in very different environments of stress? All right, so both scenarios actually lead to the same outcome through the same mechanism, and that's understimulation of the tendon cells. If no load is applied, obviously the tendon cells won't be stimulated. But in the case of too much load, it's not quite as intuitive. As I mentioned in the overstimulation argument, there can be irreparable harm done to the collagen structures if you repeatedly load it cyclically. And in such an instance, the mechanism for sensing that mechanical stimulation is lost. And so in essence, the tendon cells are mechanically silent, even in spite of large stress application. All right, so what this means is that both excessive and low load conditions perpetuate this process. So if a structure is understimulated, the mechanical integrity will be diminished due to the tendon cell mediated degradation. And this is going to leave the tissue vulnerable the next time it's loaded. And that could lead to the fibrillar damage and then the loss of mechanical integrity. And that's just going to perpetuate itself. So it's a really ugly snowball effect that can occur here. All right, so ultimately, this can lead to tendinopathy. And that term is intentionally broad. It's used to denote a pathology of the tendon without really going into any specific reference into the mechanism. So Jill Cook first proposed this was a continuum in 2009 with her paper on that, and she's since refined that a little bit. And anyone who's not familiar with her model, I just really can't recommend enough going out and kind of reading up on that, because I'm not going to get too much into that today because it's not pertaining too much to what I'll be talking about when it comes to prescription, but it's really important to know from a framework. Basically, what she says is that there are three main stages of tendinopathy, and that's going to be reactive tendinopathy, tendon disrepair, and then degenerative tendinopathy. And then importantly, you can have kind of a mixed situation where you have a reactive tendinopathy within a degenerative tendon, and that's reactive on degenerative there. So not to be a Debbie Downer here, but there's little to no evidence to suggest you can alter tendon characteristics once you're in the degenerative phase. But there's some good news in that when they've looked at tendons using ultrasound imaging, they've actually shown that pathological tendons have an increased mean cross-sectional area compared to quote unquote normal tendons. And so while there's a reduced relative percentage of aligned collagen structures, and we're talking absolute terms, the tendons actually contain increased amounts of load-bearing structures. So what Jill Cook and one of her colleagues, Sean Docking, have proposed is that you should treat the donut, not the hole. Or in other words, your treatment should be aimed at imparting influence on the remaining viable collagen structures, or the donut in this metaphor, rather than the degenerative aspect, or the hole. That's all good. So what are we actually doing with our treatment, right? So our main goal is to enhance the tissue's capacity, and that's going to be defined as the tissue's ability to perform functional movements at the volume and frequency required without exacerbating symptoms or causing injury. So specifically, what are we impacting? Primarily, we're going to be influencing tendon stiffness. When a pathological tendon remodels, the majority of the newly integrated collagen is actually type 3 collagen rather than type 1. And that's the predominant collagen present in healthy tendons. So type 3 collagen is actually more compliant than type 1. And so we're essentially just attempting to restore the normal tendon mechanics by increasing stiffness, while we're also attempting to improve the tensile strength back to their premorbid levels. And this is done primarily by adding or removing material. And so that goes back to the crosslinks we were talking about earlier and having some impact on the proteoglycans and some of the matrix in between the collagen structures as well. And now I have a big question mark next to cross-sectional area here. The data on tendon hypertrophy is a little bit mixed and it's a little bit contentious, but it still may be occurring and may be really important in terms of affecting the tendon dynamics. So it's still thrown out there, but it's not quite as well established as some of those other principles as well. All right, so how are we driving these changes? A key concept here is going to be the idea of mechanotransduction, or the mechanism by which cells convert mechanical stimuli into cellular responses. And you'll see other terms thrown out there a lot, like mechanobiology, which is just this concept applied within a biological organism, or the term mechanotherapy, which simply frames this in a rehab process. So mechanotransduction occurs when there is a mechanical stimulus applied to the body. The force is imparted at the tissue level, or the macro scale, and then the tendon cells then sense that load, and if it's sufficient, it'll initiate a molecular response. The coupling right here, the one between the tissue level and the cell level, is the primary concept we need to understand for today. So this is the step that is lost when the tendon is in the degenerative phase, or that the tendon is now so denatured that it can no longer detect and respond to stress. And that's going to leave us unable to drive any adaptations. So this mechanical silence is why any intervention proposing to restore normal tissue quality is probably bunk, because there is no viable mechanism which we can influence that tissue. We can only impact the surrounding structures here. And this slide just highlights this process. The protein up in the top right, the integrins, are the ones that are primarily talked about in the literature. I'm not going to go into this today. You really don't need to know this, but it's just an interesting concept. And if you want to learn more about it, just check the reference there, the Thompson paper, or some of Karim Khan's work. It's really good. All right. Finally, to the part where we begin to translate this into the gym setting or the clinical practice. So I've written about tendon management in the past, and one complaint I've got was how I don't give enough specifics regarding what to do within a treatment session. But I do this deliberately. What I do is I outline the inputs which matter to the tendons, and then I allow you to manipulate those inputs to fit the needs of your athletes. So it's not going to be a cookbook approach here, and it's not going to be anything which you can just repeat with everyone, but it's going to be a set philosophy which you can pretty much translate to anyone you'll be working with. So Peter Malliaris, I always butcher his name, but him and a couple others have broken down tendon rehab into 4 phases, which I find to be really useful. So I lump phase 1 and phase 2 together here because rarely will you have anybody who is so reactive that they can only, tolerate pain management strategies. So phase 1 is pain control, and phase 2 is strength. So to begin each treatment session, heavy isometrics can serve 2 important roles. When performing 5 45-second isometrics at 70% of their 1 rep max, researchers demonstrated that you get an analgesic effect, but you also get an influence on the neural drive to the adjoining musculature. So you get a reduction in cortical inhibition for at least 45 minutes following that. And that's going to allow you to impact the tissue around it to a greater degree and maybe drive adaptations more. So within that window of time, you can use heavy, slow resistance training to influence the tendon strength and capacity. And I use heavy, slow resistance here because a lot of the literature shows that the contraction type probably doesn't seem to matter. And so I'll give my patients their choice of loading options, but most often HSR is simple and it's familiar, so it's just the easiest one to use. All right, so now kind of the nuts and bolts of what we do. Selecting exercise. Early in rehab, we want to avoid putting the tendon under simultaneous tensile and compressive loading. And this is especially true for insertional tendinopathies, like the Achilles tendon where it inserts, or the inferior pole of the patellar tendon. But this generally holds true for other tendons as well. So for example, you want to avoid deep knee flexion with the patellar tendon. You want to avoid dorsiflexion beyond neutral for the Achilles tendon. You want to avoid adduction beyond neutral for the gluteal tendons, and so on. Second, you really want to include compound movements within their training. This is going to allow you to include high absolute loading, and so you can maintain some sort of training effect while you're going through the rehab process. And then finally, you want to make sure you have some sort of an isolated movement variation in there as well. So if I use the patellar tendon as an example, if you only squat the patient, there's so many movement strategies they can adopt to relatively shield that tendon from accepting load. So if you do something isolated, like a leg extension, you can make sure that you're loading that tendon deliberately to drive adaptations. All right, so with all that being said, how much load do we want to apply? So what we want to do is find the patient's individual optimal load, or the load that maximizes physiological adaptations. And we achieve this by manipulating intensity, frequency, volume, and rate. And I want to explore those a little bit more here. All right, so intensity of loading, it seems to be a primary factor for tendon adaptation. Unlike muscle tissue, which is extremely sensitive to a wide variety of stimuli, tendons require a little bit more specific loading parameters. So most often it's been noted consistently loading tendons under 70% of 1 rep max fails to induce physiological adaptations. Returning back to the idea of collagen crimp, each fibril is not the same length, and fibrils within the same fiber demonstrate unique crimp patterns. Therefore, to ensure that the crimp is taken out of all relevant collagen fibrils, and therefore ensuring that load is being transmitted through all of those fibrils, you need to strain the tissue above a certain threshold. So it's been proposed that this threshold is around 70%, and you need that to influence the tendon on a structural level. But I should point out that this has mostly been looked at in energy storage tendons like the Achilles tendon and the patellar tendon. And it doesn't really hold true for all tendons. So like when they look at the supraspinatus, you see kind of equivalent outcomes when you're doing low load and high load. So understanding the type of tendon you're working with matters. Energy storage tendons have greater toe regions than positional tendons, meaning the intensity requirements may be kind of more specific with them. So to ensure that you're getting all that relevant slack out, I'm really cognizant of how much load I'm using when I'm working with an Achilles tendon or a patellar tendon. When, say, if I'm working with supraspinatus, I'm not nearly as concerned. All right, so all that sounds great, but how do we make this a reality in clinic? Not everybody we treat is going to be as enthusiastic about training as we are, and they won't be able to spit out their 1-rep maxes on command. Most often, our patients won't be appropriate for true 1-rep max testing. So how do we determine where we load them, right? So a strategy I really like early on, especially for isometric loading, is going to be using a blood pressure cuff. So using the supraspinatus as an example, you can wrap the cuff bladder around the athlete's wrist, inflate it a little bit, and then have them perform an external rotation into the wall. So this may be self-limiting, they may have some pain, but regardless, you'll get some sort of indication on their maximal tolerance. And then what you can do is you'll take that number and use that as your reference point. So I'll get whatever they got in terms of millimeters of mercury. I'll take 70% of that, and I'll tell the patient to keep the needle at that point or above for that 45-second duration. And you can also do this with the patellar tendon as well. So if you place the bladder around the lower leg, you can put a gait belt around a table and then have them perform a leg extension into that gait belt. So that also works really well. All right, so say you've got more traditional resistance training experience with the athlete and you have ways of loading them to do that, but they're still not right to kind of 1-rep max test. Obviously, you could do something like a plus set to kind of get a good estimate. So after warming the patient up, you'll have them perform a set to technical failure with a moderately heavy load, and just take the weight used and the reps and plug it into this formula. It'll spit out a rough estimate of the 1-rep max, and then you can use that for guidance going forward. Is it perfect? No, but it doesn't need to be. Again, we just want to get in the ballpark to make sure we're getting enough load to drive those adaptations. And then finally, a really common problem that maybe some of us face is that we don't have the equipment in the clinical setting that we'd like. Or maybe the athletes themselves, when they go home, maybe they don't have gym access, but you still need them to be consistent in their loading. So it's just going to take a little creativity, but you can almost always find some body weight or light dumbbell weight, variation that is going to max them out at 12 to 15 reps. And then use that as your starting point and kind of push them from there. Again, that gets you in the ballpark of loading enough to create those adaptations. All right, so the next variable is frequency. There was an important paper put out by Magnuson in 2010 when they examined protein turnover following bouts of loading. And so what they discovered was that for approximately 36 hours immediately following, there's a net loss of protein. And you don't see a gain until after this point. So what this means is that we should really try to space out our training by at least 36 to 48 hours to ensure that there's some period where there's net synthesis. So you're going to have some accrual of protein there. All right, so intensity and frequency are, for the most part, relatively stable throughout this process. These next two variables, volume and rate, are two which are going to be adjusted fairly deliberately and need to be monitored closely throughout the phases. When it comes to quantifying load in terms of volume, there are a couple different methods out there. But what I just try to keep it simple, and I'll just calculate their volume load, which is multiplying the reps times the weight they're using on their main movements. Our immediate target is somewhere between the patient's individualized minimum effective dose and their maximum recoverable volume. To get here, my recommendation is to simply underestimate them up front, and then you can always load them gradually from there. Tendons are really poor at providing instantaneous feedback, so you won't know if you've loaded the structure too much until after the fact. So again, just start low and build up. Ultimately, we want to keep our end goal in mind here. Our goal is to build the tendon capacity to the point where they can withstand loads similar to that of their toughest training block. So always keep that in mind when you're progressing the volume as well. So to hark on this again, understanding the tendon you're working with and the physiology behind it really may matter. So energy storage tendons display significantly greater fatigue resistance than positional tendons. So there's probably a lot more wiggle room when you're working with an Achilles tendon in terms of the volume. So with positional tendons, I tend to keep the overall volume much lower and make smaller jumps when it comes to progressions. All right, finally, rate of loading is extremely important for tendon management. This is going to go back to that viscoelastic nature of tendons and how they are rate dependent in their changes in dynamics and stress application. So when you look at some of the data on stress levels within tendons, there are a few interesting findings. For the Achilles tendon, when you perform a maximum isometric plantar flexion, you get approximately 3.5 times body weight stress. And then compare this to the 6 to 10 times body weight stress when you're running or performing submaximal hopping. The patellar tendon has roughly similar levels of stress when you're comparing squats versus stop jumps, but importantly, the strain rate differs greatly. So it's only 1 to 2 times body weight per second if you're squatting, compared to the 40 times body weight per second loading of that tendon during the jumping scenario. So what this means is that tendons are extremely sensitive to high velocity loads and need to be really deliberate in terms of your manipulation of that variable to ensure tolerance. This is why slow got incorporated into heavy slow resistance training. So a little clinical tip, one thing that I use to quantify the rate early on is just to use a metronome. And you can download the app on your iPhone for free or get your patients to get one for home. And what I'll do is I'll typically just have them perform the movements to some sort of external cadence. So that way you're controlling for this variable. All right, now we know what to control for, but how do we know if we've gotten the right balance? So a feedback mechanism commonly used is a 24-hour pain response. First of all, acute pain doesn't correlate well with outcomes, meaning that even if the exercise is mildly provocative, it doesn't mean it's a bad thing. In fact, a lot of researchers have even hypothesized that it may be beneficial from a psychological and physiological standpoint to exercise into a little bit of pain. But chronic pain, so pain following for a couple days, is something that's almost universally recommended to avoid. And this is where biofeedback training comes into play. So you want to find a movement that deliberately loads the tendon you're treating and have the athlete perform that and give it some sort of rating on a 0 to 10 scale. And you're going to use that number as your baseline. So then you're going to have the athlete test that same movement the day following a training session, and then you want to monitor their response. So if you see that number consistently elevated, it may mean that you're doing too much and you need to manipulate some of the variables I outlined above. All right. So I want to point out that we're not just having patients come in and perform 1 or 2 exercises specifically for their tendon and then calling it a day. We don't want to forget about the rest of the body here. This is a long process. Tendons require at least 8 to 12 weeks before you see signs of physiological adaptation. We can't afford to lose that time in terms of their other potential adaptations. So one of the first things I try to do with my athletes is reframe how they view their injury. I try to get them to see that it's an opportunity to focus on their weaknesses, maybe that they've been neglecting, rather than just a burden. So not only is this important to consider from an opportunity cost standpoint, but there may also be important implications for the tendon rehab itself. Areas away from the tendon can meaningfully impact the stress on that tendon. If we improve strength or coordination at proximal or distal sites, we can offer the patient new movement strategies and increase their variability when it comes to performing their sport-related demands. So for example, if you work on ankle or hip mobility or stability using some of the videos Quinn has put out there, you can give somebody new options when it comes to squatting, landing, cutting, etc. And you can change the total load placed on their tendon. So this will allow you to endure the chronic stress during training that maybe you wouldn't have been able to before. And you can draw this out to many different examples. So if you're working with somebody with some sort of shoulder dysfunction, say you give them more rotational power or better scapular strength and stability, you can again impact the stress at that site. So it can be really important for that as well. And then finally, an often overlooked consideration is the energy demands required of that athlete in their sport. Scott Morrison authored a great paper on this recently, and he points out the importance of maintaining or developing these qualities during rehab, not after the fact. So of course, being specific is best, but you don't need the same training modality to improve the energy system. So for example, if your patient's unable to tolerate loads associated with running, you can sub in other more tolerable forms of exercise, like an airdyne bike or a rower, and then just simulate the work-rest ratios they need. And this is going to allow you to develop those qualities and have a much easier transition to later phases of rehab and getting back out on the field. All right, so now we move on to phase 3. This is when energy storage type stresses are introduced to the tendon. And you can think of these as higher speed, more force absorption tasks, or kind of your lower intensity or lower volume cyclical loading. And this would encompass things ranging from landing from a jump to even a small number of rebounding plyometrics. Often the criteria used for you to enter this phase are that the absolute strength of the tendon needs to be at some certain threshold, and then the tendon needs to demonstrate tolerance. And when they define tolerance, they mean less than 4 out of 10 pain while you're doing an energy storage movement with no evidence of worsening after the fact. And when it comes to strength, there are a couple of criteria out there in the literature when it comes to entering this phase, but they seem a little arbitrary to me and potentially a little excessive, because one of the criteria is going to be 4x8 of single leg presses with 150% body weight. Like, that seems like a lot to me. And I'm really not going to hold somebody back from entering this phase if they fail to hit that target. So I have other strategies I like to use to determine this step rather than some of those guidelines put out there. I much prefer assessing symmetry during isolated strength tests and then assessing quality and tolerance during small progressions along this force velocity continuum. In phase 2, we kind of live and breathe on the left side of this force velocity curve where we're trying to build maximum strength and tendon capacity. But when we're given the green light to work on energy storage demands, it's a mistake to jump down here to the opposite end of the continuum. Instead, what we want to do is progress them gradually to this point to ensure that the tendon can handle that type of stress. So for example, I almost always introduce velocity within the rehab setting by manipulating the speed of the movements I've already introduced during phase 2. So I make little jumps along the continuum down here, and I'll do that using the metronome as before. I'll just make smaller, deliberate changes in terms of the speed and tempo. All right, so there are a lot of options to progress in this phase. I just wanted to highlight a couple that I like that maybe you haven't seen before. These concepts are taken from Cal Dietz. He's a strength coach who wrote a really influential book called Triphasic Training. And I'll just use a couple of examples of movements I really like with athletes during rehab of patellar tendinopathy. So the first one I'll click on here is going to be a great way to build confidence, control, and capacity within a large excursion task. All right. I don't know if you saw that or not, but basically what the person is trying to do is rapidly pull themselves downward during the eccentric portion of a squat and then try to stop themselves quickly without letting a downward creep happen. So this athlete had a barbell on his back, but I'll typically introduce this without any type of external load to start. And this is something that I'll use typically right before plyometrics because this builds a ton of capacity needed to tolerate high velocity eccentric stress. In the next video, it's pretty short, so I'll try to play it a few times. Hopefully you'll be able to see it. But the athlete is going to go through a small amplitude but rapidly changing direction movement between the concentric and eccentric. And this is a great stepwise progression to get towards those cyclical loading. So in this video, you can see they're doing it in a split squat or a lunge position, And that can be really useful to develop position-specific strength and power like you're going to need during cutting tasks. So yeah, really short, but just wanted you to see the rapid movement, the oscillation there, trying to change between concentric and eccentric. And then a side benefit or an additional use of the latter half there, with movements like this, especially in the later half or later stage of phase 3, you can continue to work on energy system development. So with a movement like that, you can adjust the work-rest ratio and then have them build some serious anaerobic capacity. And usually that's pretty well tolerated by the tendon as well. All right, so how do we program during this phase? One of the largest components here is being able to accurately quantify the loads you're applying to the tissues. So for this, you're going to want to closely examine the movements you ultimately want to achieve and figure out stepwise progressions to reach that point. If you're unfamiliar with how to quantify some of those loads and don't understand kind of how they impact the stress, I'd really recommend just checking out some of the resources by the NSCA. They've got some really good material to get you caught up there if you don't know. I just gave a quick example here of some jump progressions, but this is far from all encompassing, and really there are a lot better ways to go about it than whatever I put there, but just to give you some indication. So next, over time, the common consensus you'll see in the literature pertaining to tendinopathy is that you want to progress volume before you make a drastic change in intensity. The problem with all this literature is they never give you specific parameters on how much volume to change before you change the intensity. The best advice I can give you is to just be logical. A lot of this is going to depend on so much of the context of the situation. If you're performing a higher intensity jump, say that can matter between ground contact time, if you're doing a double versus single leg jump, the height of the drop, if you're rebounding or not. You want to look at the intent of the movement. You want to look at the athlete's characteristics. So their size, their body composition, all of that is going to matter in terms of your volume prescription. But you just want to be logical here. You want to start small and progress a little bit at a time, right? When in doubt, do less when it comes to tendons and just make sure tolerance is there. And then finally, we actually want to space out our energy storage days a little bit more than usual. So a standard template is going to be something like this, where day 1, you would do your high load, so your energy storage. Day 2 would be a low load day for pain management, like your isometrics. Day 3 would be a medium load day, so your isotonics. And then day 4 would be an off day, and you repeat that cycle. So what this does is it allows you to develop tolerance to those high rate stresses while still addressing capacity throughout this phase, which is extremely important. And lastly, of course, you want to carefully monitor the response here because, again, tendons are pretty sensitive to this type of loading. All right, phase 4 is the sport-specific or elastic function phase. And here we're going to be applying energy storage and release type loading. So if you do a drop landing in phase 3, instead you'd be performing something like a depth jump. Instead of low load plyometrics, you're performing more kind of sprint and agility drills. So this phase, in terms of the parameters and progressions, it's really similar to phase 3. But the main difference now is that we're really attempting to approximate the sport-specific demands and get to the typical loads that are placed on that tendon during practice and games. So for the last time, I just want to reinforce that it's so important to become more specific with your energy system development here. Improving fatigue resistance helps out a ton from a performance standpoint, but it's also going to be really important from an an injury reduction standpoint as well. It's just something to consider while you're rehabbing the tendon to build up this quality. And if you're not familiar with how to develop those, this table right here can give you a really rude introduction to it. But again, I would check out some of the NSCA materials there. All right, so things change a little bit if you're dealing with an athlete in season compared to off season. A major difference is the way pain is viewed during this process. So isometric and isotonic loading below painful thresholds both display pretty much equally effective outcomes during this time. But when loading into pain, patients tend to fare a little bit worse here with increased irritability chronically. Therefore, it's often recommended to really keep loading pain-free during this phase. Additionally, if you have any say in the total volume and frequency of training, you can have a huge impact on their injury risk. So athletes with less than 2 days of rest per week in season have a 5.2-fold risk increase for an overuse injury compared to those with greater recovery. And that's huge. I really can't overstate that. So if you're not the one calling the shot on this, at least educate your patient, their parents, or the coach would be even better on this to let them know how important it is to make sure you're getting adequate recovery time as well. All right. Lastly, strategies to reduce further injury. You know, the easiest advice I can give would just be to simply avoid detraining. You know, you see major changes in tendon characteristics within 4 weeks of stopping training. I outline a bunch there that have been shown in the literature, but it is pretty massive. So if you can avoid that, if your athlete is beginning training after a period of inactivity, whether that was forced due to injury or you were just kind of not training as hard as you should have been during the off season, you really want to proceed with caution. You want to pay close attention to the external loads and be careful to monitor the acute to chronic workloads to ensure that you aren't making too big of changes in too little time. And then the last thing I want to say before I take questions is I just want to give a disclaimer on this, that clearly this isn't the only way to treat a tendon. Like, there are a lot of success stories out there using very different approaches. And in fact, restoration of structure isn't necessary for resolution of symptoms. There's a known discrepancy between tissue quality and pain perception, and this means there may be a large impact of the central nervous system or even psychological conditioning that may be impacted by a wide variety of exercise interventions, not just how I outlined it here. This is simply my interpretation of some of the literature that's out there, and that's always subject to change based on what comes out. So that's kind of all I had. I have a whole bunch of references, and then I give my contact information here for anybody who's not live right now that wants to reach out and maybe ask me something. But with that, I mean, I'll just kind of open it up to Quinn or anybody that had questions.
I wanted to bring attention to the 2 blog posts that you've written, Jason, on tendinopathy, one of which is called Squatting with Patellar Tendinopathy, and the other is Training with Biceps Tendinopathy. Those are 2 blogs that you wrote on strongerbyscience.com, which is Greg Knuckles' blog, and I also linked those in the chat box so people can jump right to those. And you were just on the Clinical Athlete podcast not too long ago talking shop about tendinopathy. So we had a really good discussion and had a lot of great feedback on Clinical Athlete podcast number 3. And so I linked that in the chat as well for people. And you mentioned early on about the importance of also having some type of isolated movement in there for rehab so that you're not, so the person really has no choice but to load the tendon. And you referenced the leg extension as one, which is interesting because of this kind of back and forth over the years that we've had in the rehab world against leg extensions. What is the narrative of the demonizing of leg extensions? Where is that coming from, and is it valid in any form?
That's a good question. So it comes down to load is load, right? The body responds and adapts to load being applied to it. It's the dosage that can be the problem. So there are certain scenarios where it may not be beneficial, like really early on following an ACL. But even they're coming off of that, and there's some really aggressive protocols that don't really have that much restriction on that. But that's a different topic. But when you look at some of the data, I guess people freaked out about the loads going through the patellofemoral joint. But again, as long as you understand the positions that are sensitive and you let the patient kind of self-modulate based on their symptoms, there's no problem with it as far as I'm concerned. And when we're talking about loading the tendon, I don't know that there's a better way to direct it specifically to the patellar tendon if you're doing a leg extension.
Yeah, it makes sense to me. Lachlan has a question here regarding the blood pressure cuff placement. When you were talking about that as far as testing, with blood pressure cuff placement, why distal rather than proximal? Everything that I've been taught thus far has said proximal to the joint. curious to the mechanisms as to why this change in placement affects tendons versus muscle change. I think she may be making a parallel to blood flow restriction.
Yeah, that's what it sounds like. Oh yeah, that's what it sounds like. No, so this is not used to occlude in any way, shape, or form. You just want a very little amount of air in there so you can get a reading when you put pressure into it.
Okay.
So you just want it at the distal site you're actually applying pressure to. You're not actually trying to prevent any venous flow.
It's just giving you a reference point, right? As far as
exactly.
Yeah. And then you mentioned avoiding in the early stages, avoiding compressive loads to the tendon. And one example was a deep squat for the patellar tendon. And I'm assuming deep means anything below, like, 90 degrees or below. Are there any guidelines or reference points to when compression loads would then be appropriate to start adding back in? Is that just, through the later phases?
As far as I know, there's no definitive guidelines on that. Actually, with the patellar tendon, that one's kind of a weaker example because that isn't that big of a deal when it comes to loading that tendon. But some of the other ones is a bigger factor. I would say just modulate it based on the patient's tolerance. And if they need to get in those specific positions for their sport, you definitely want to work on it probably to a greater extent than if they don't. But it's hard to say. You kind of have to individualize it based on their response.
Matt asked a question here. Is tendon health genetic in any way? Can people just have a poor predisposition to weak or fragile tendons?
Yeah, so there's a couple of different theories regarding the pathology of tendinopathy, and it seems that intrinsic factors probably have a bigger determining factor than extrinsic factors. So things involving your genetics and your heritability of some of these traits play a large role in the ultimate health of the tendon. And so that's why you see a lot of tendinopathies later in life, even if the people, it's regardless of their physical activity levels, because so much of that is determined genetically.
The nature of the modulating or monitoring the pain as far as the 24-hour rule, is there any concern in regards to the athlete ruminating on the pain scale and just kind of, perseverating on, am I a 1 or a 2 out of 10? I can't really tell. It's been, 30 hours and not 24, and I don't think I'm back down to baseline. Do you have that conversation up front that we're tracking this stuff, but don't be too obsessive about it?
Yeah, absolutely. And you have to be able to read your patients. You got to know who's going to be a little bit neurotic about it and who's going to take that and run with it in a negative way. So you want to have that conversation about how pain doesn't necessarily signal damage, and then talk them off the ledge if they're going that route. Let them know you're expecting some sensitivity. You deliberately loaded it. It could be sore. But you just have to make sure you talk to them about just not seeing a steady incline over time to the point where it becomes intolerable. But yeah, absolutely. Take their psychological characteristics into account.
Brandon asks a good one here. Where does manual therapy come into play when treating patients with tendinopathy in your plan of care through those stages of rehab that you described?
When it comes to the tendon directly, very little for me, because there just doesn't seem to be a plausible mechanism between some of the loads you'll be applying to the tendon and some of the changes we're trying to create. Now, you can make a good argument for, maybe some distal sites to afford different movement options. People can argue that, and I won't fault them for that. For me personally, I don't use a ton. I find different loading strategies or different, just activities are better use of my time. But again, I'm not going to discount other people who have success using it in other ways. But I wouldn't view it as something that's going to be beneficial to changing anything within the tendon itself.
Jordan asks, any pearls for treating gluteal tendinopathy and lateral hip pain? Do you avoid extreme increases in flexion and adduction?
So the name Alison Grimaldi, she's a great researcher talking about lateral hip pain and gluteal tendinopathy. If you haven't seen any of her stuff, I would look her up. But yeah, absolutely. You want to avoid compression with that one especially. So talk to them about sleeping postures, not directly lying on the gluteal tendon, and avoiding positions where it crosses the midline, because that seems to be really provocative. And then from there, same general principles. It's just loading a tolerable amount early on, probably starting with isometrics, is building up capacity over time.
And Lachlan asks, are there any specific nutritional strategies you'd implement? And if so, would they change according to the phase of rehab?
That's not something I'm at least willing to put a stamp on. Like, I don't have that great of knowledge in that background. I know there are a couple of people out there who do look into the effect of nutrition on some of these pathological processes, but I really don't have the information. I'm sorry on that one.
Yeah, I don't either. Sleep, I know that anecdotally for me with patellar tendinopathy, when I lose sleep on consecutive days, I seem to sensitize worse. Kind of that, like we always talk about sleep and nutrition kind of going together, but that's totally anecdotal as well.
Yeah, I mean, there are a lot of contextual factors that come into play. I mean, I don't know a lot about the validity. I mean, you'll hear a lot from athletes in particular talking about inflammation levels with certain diets. I don't know how much of that is actually, valid, but I wish it was studied more so we could have some better answers. But at least as far as I know, I don't have them.
And then Kevin follows up on the genetic predisposition question from earlier, and he asks, what should you do if you believe you are genetically predisposed to tendinopathy?
I mean, ultimately, you can't change those non-modifiable factors. All you can do is really worry about the things you can control and try to build up the capacity to the best of your ability and just go from there. I mean, I wish I had a better answer. I wish there was some better options out there for preventative nature, but I mean, as long as you're staying active and you're consistently loading that tendon and building up the capacity to your best ability, that's really all you can do.
On slide 41, the Magnuson study, talking about the kind of like almost tendon degradation post, acute workload, acute training bouts. And you mentioned, a 36-hour window to try to let it regenerate. Is that also a recommendation for those without tendinopathy and healthies?
Yeah, I mean, I think a lot of that data comes from healthy tendons. So, I mean, I think that would be a good recommendation there. Most people training, they don't do back-to-back days anyway, but just for some reason in rehab, we think that loading people every day is the best option. Now, maybe it's good from a desensitizing standpoint. Maybe it's good if you're trying to ingrain a new motor pattern, but from a loading perspective and adaptation perspective, I mean, I don't really see the benefit.
Yeah. Let's see here. Ravi, okay. Should we get away from the tendinitis/tendinosis terminology and more toward the continuum of reactive to degenerative? In school, these terms, those past terms are still kind of popping up.
Yeah, I won't vilify the terms because they still can be useful. I mean, especially when you're communicating with other professionals, they'll kind of relate more to those terms. So there's been more of an argument recently that maybe there is still an important inflammatory component during tendinopathy. It's just on a cellular level, not necessarily the tissue level or systemic level. So it still may be important. But from our standpoint, managing it, it seems way more important to just understand how it tolerates load and not really worry so much about things we can't control or even like really with any sort of validity assess. So I much prefer the generic term tendinopathy, and I don't really use the others.
A follow-up question is on that. Does tendinopathy assume symptoms, and tendinosis would maybe just assume you would see degenerative changes and not necessarily with symptoms?
Yeah, I'd say that. That would, more denotes the structure rather than any symptoms.
Got it. Jeffrey asks, how do you program Achilles tendinopathy in runners? Well, I'm assuming you're not programming Achilles tendinopathy, but for Achilles tendinopathy in runners who aren't as willing to perform traditional strength training exercises and want to continue running as a primary means of exercise. Good question.
Yeah.
Do you have he finishes up. Do you have a volume-based approach to taper off the irritability in the 24-hour pain, and the 24-hour pain level?
Well, so first to tackle the running question, I mean, that can be really difficult. And I'm sure we've all treated a runner or at least know somebody who runs who can be kind of stubborn like that. I mean, there are, I want to say Rich Wiley, And I think Chris Johnson's a great reference when it comes to managing anything in runners. There's some differences in their gaits which can impact the stress on the tissues a little differently. Tom Goom, he's a guy as well you want to look up when it comes to managing in runners. So you can look at different gaits and how that could affect the stress on that tissue specifically, and see if they're at least more willing to manage a small change in their running type. You can also talk to them about simply managing the volume within their running training, see if they're more willing to at least accept that, and see if that's enough to at least get them below the provocative threshold. Obviously, you're going to want to sell them somehow on more traditional training, but that can be an uphill battle. And what was the second question, Quinn?
And then he follows up with, do you have a volume-based approach to taper off for the irritability and the 24-hour pain level? Basically, if they flare up, are you then tapering off of the volume that way, or are you just waiting for the irritability to die all the way back down before they train again?
So I guess it depends on the level of irritability and their tolerance to stress at that point. So for me, if somebody comes in and they're really irritable, I'm going to start them with more kind of the phase one movements up front and see how they tolerate that loading, and then just very slowly ease them into whatever phase I'm working on to see how they're tolerating it. I don't have any specific guidance in terms of volume, but you just got to kind of play it by ear based on their sensitivity.
If you've got the 3-day-a-week program, and let's say you dosed them on Monday, and you were planning on doing another workout on Wednesday, but they were still a little bit hot from Monday, do you cut out Wednesday completely and just let them die back down all the way to, baseline levels of pain, or do you just modify the dose of what you were going to give them on that Wednesday workout?
Well, it depends on how sensitive we're talking.
Right.
So, if they come in and they're really agitated, I'm definitely not going to do some of those higher. If I'm, say, in phase 3 and I'm working energy storage, I'm definitely going to dial it back on those and maybe not even include them that day. Because, again, you just have to monitor that response, and you don't want to just, jam that square peg into a round hole. You have to take it as it comes.
It also sounds like this is why you can't really recommend a cookie cutter approach, because you just don't.
Exactly. There's so many individual factors that come into play. So it's very hard to make any specific outline for somebody. You just have to have a good understanding of the inputs and how to manipulate them.
And then Matt asks, with people who present with healthy tendons, is it worth doing any isometric or preventative training as part of a warm-up or accessory work, or best to continue training as per normal?
I mean, I don't see any harm in it. I don't know if it's specifically indicated. I don't know if it'll offer you any benefit over just simply doing warm-up sets with lighter weight and just easing into it. I mean, I think they've actually looked at that a little bit when it comes to in-season management for athletes, and it's just, it doesn't seem to make a difference. So I just err on the side of doing whatever they're comfortable with.
And Kevin asks, if ibuprofen is contraindicated in any particular situation, is Tylenol valuable for initial management of a reactive tendinopathy?
Man, I saw this in a paper just the other day, and I didn't click on it to read. I really wish I had now. I know that's been looked at when it comes to the non-steroidal anti-inflammatories and a response within tendinopathy. My gut reaction is to say that paper talked about it not being beneficial to include that during the time, but I'm not sure. I would definitely look that up. Don't take my word for it here. So I really can't give you a good answer, unfortunately.
Yeah, and then as far as the comparison or differentiation between ibuprofen, if that's contraindicated, and Tylenol, again, you kind of have to make sure there's no contraindications in general, so it's case dependent, but it's hard to answer that one. It's tough to say.
I mean, I imagine the dose is going to affect that as well. Like if somebody's really high on their dosage of the anti-inflammatories, then it's probably going to matter to a much greater degree than somebody taking 1 or 2 ibuprofens when they're in a little bit of pain. So I mean, it's definitely going to matter on the context there as well.
Yeah, and with Tylenol, we're assuming it's just pain management here, and don't forget what Jason had mentioned earlier, that isometrics can have an analgesic effect as well. So
exactly.
And you might find that you don't actually need the NSAIDs or the Tylenol, and then you can actually impart some load on the tendon by doing some isometrics. So that's what's so cool about that. Oh, Brennan references a paper here that said there was a paper by Lesia B. Lesia, I don't know if I'm pronouncing that correctly, et al. In 2017 talked about NSAIDs and muscular strength training. High dose OT over the counter of ibuprofen reduced strength and muscle hypertrophic adaptations. Okay, so that's just interesting in general. It seemed to blunt the training response.
Mm-hmm. That must have been the one I saw but forgot to click on. Yeah, so I know, like, I'm glad you pointed that out. So if that's something you're interested in, definitely look into that and let me know.
Thank you so much, Jason. That was absolutely awesome information. For everybody listening, I would highly recommend you watch the recording as many times as you can, because I think every time that you would watch it, you'll kind of put together more and more of the pieces. And definitely check out the blogs that Jason has written on this topic and his contact information. And just, as an FYI to everybody, Jason is a valuable contributor in the Clinical Athlete Forum as well. So we're lucky enough to have him in there. Thanks so much, Jason. We really, really appreciate it. It was awesome. We'll have to get you on for another one.
Yeah, thanks for having me, Quinn. I really appreciate the opportunity.
Absolutely. And for everybody else, thanks for listening, and we'll see you on the next webinar.